Welcome to the Friends Residency platform, which is the ultimate learning platform for residents preparing for MDMS university exams. I'm Dr. Shumosri, your pediatrics faculty, and today I'll be guiding you through the topic of non-hemolytic febrile transfusion reactions to help you excel in your upcoming exams. So, non-hemolytic febrile transfusion reaction, or NHFTR, it is one of the most common adverse reactions to blood transfusion, defined as fever, with or without chills, occurring during or within 4 hours after a transfusion in the absence of hemolysis. Coming to the pathophysiology, immune-mediated mechanism caused by recipient antibodies reacting to donor leukocytes, platelets, or cytokines present in the transfused blood product. Cytokines like interleukin-1, TNF-alpha, they accumulate during blood storage and they trigger the febrile responses. Non-immune mechanism, release of pyrogens from donor leukocytes during storage. The clinical features are fever during or shortly after transfusion. They can be associated with chills and rigors, occasionally associated with headache, nausea, or myalgia, but there is no evidence of hemolysis. So there will be no hemoglobinemia, hemoglobinuria, or significant drop in hemoglobin. The risk factors: recipient related, history of prior transfusions or pregnancies which leads to sensitization to leukocyte antigens. Okay, and pre-existing immunological conditions. Donor related, prolonged storage of blood products, increased cytokine accumulation occurs in blood products that are stored for a long time. The type of blood product, more common with platelet transfusions due to higher leukocyte content in them, less frequent with leukocyte reduced RBC transfusions. Coming to the diagnosis, the clinical diagnosis: if there is fever during or shortly after transfusion in the absence of signs of hemolysis or infection. Okay, so we have to exclude other reactions, rule out hemolytic transfusion reaction, sepsis, and TRALI, transfusion related acute lung injury. Going for the lab tests, there is negative direct antiglobulin test, that is, there is negative DAT. So what do we go for? We go for direct Coombs test. And it is negative. Absence of hemolysis, so there is no elevation in LDH or bilirubin. Blood cultures from the patient and transfused product to rule out bacterial contamination. What about the management? Immediately what we have to do is to stop the transfusion immediately upon onset of symptoms. Maintain IV access with normal saline. Symptomatic treatment: we have to give paracetamol to manage the fever. Antihistamines are rarely required unless allergic symptoms coexist. And if allergic symptoms occur, we should give promethazine, popularly known as Phenargan. Evaluation and monitoring should be done. Monitor for progression to severe reactions like TRALI. Document the reaction and report it to the transfusion service. In our case, we report it to the blood bank. How do we prevent NHFTL? Number one is leukoreduction, use of leukodepleted blood products by minimizing leukocyte and cytokine content. Pre-storage filtration prevents cytokine accumulation during storage, and pre-medication, prophylactic use of antipyretics or antihistamines may reduce the severity of symptoms only in susceptible patients. Do not use these in all patients. Prognosis. And we can also prevent it, at the fourth point, as using fresh blood products, especially in children and especially in neonates. We should also see if the blood products are fresh, preferably within 7 days of collection. Prognosis: it is self-limiting, resolves within a few hours without long-term complications. And if it is appropriately managed, it doesn't really have any effect on mortality morbidity. Let us see what are the other transfusion reactions. One is hemolytic transfusion reaction, allergic reaction, septic reaction. Also, there are others like TRALI, TEPCO, and there can even be infections like CMV, HIV, hepatitis B, hepatitis C. Those are usually long term complications. Short term, we have hemolytic transfusion reaction, allergic reaction, septic reaction, which we can confuse with NHFTA. So, the management is also outlined in this table. So what are the key points? It is a benign reaction, primarily due to immune responses or cytokine accumulation, and more common in platelet transfusions and in non-leukoreduced products. Prompt recognition and management will ensure favorable outcomes. Thank you for learning pediatrics with me today. For a more detailed and exam-focused approach, download the Friends Residency app. And don't forget to like this video, share it with your fellow residents, and subscribe to this channel for more content.